SWOG S1011 was conceived, probably started working on it in earnest in 2010. So there was, you can call it dogma, but accepted practice by many of us who had trained with Don Skinner at USC, and we taught our trainees as well that for patients with curable, predominantly urothelial muscle-invasive bladder cancer, that a bilateral pelvic lymphadenectomy was standard of care, results in a low local recurrence rate, identifies most patients with pathologic positive nodes, but that dissection really should be taken up, so to speak, in an extended template, at least up to the bifurcation of the aorta, so defined anatomically, very precise. But yet, at the time, there was no level 1 evidence to really support it. And when you looked at other organ site cancers, there was similar trials that had been done which did not show a benefit, and at least in one, the gastric trial reported from Japan and New England Journal of Medicine showed that there may be more harm, so to speak, more toxicity associated with it. So with our, in SWOG, Ian Thompson's our chair of the GU committee, Ian said we should do this trial. And I said, great, I'm in. Trial asks a basic fundamental question that in patients undergoing radical cystectomy, does an extended node dissection provide improved disease-free and overall survival compared to a bilateral standard node dissection? A couple of unique aspects to the trial is that this was a limited institution trial, a selected group of urologic surgeons who met certain specifications of doing 30 cystectomies a year, the hospital 50 a year over 3 years. All the surgeons were credentialed by submitting op and path reports from 5 cases, videos or photos, most of them were photos, and in 27 centers. So patient gets registered, and then the cystectomy starts, and the first thing we do is an exploration to rule out metastatic disease outside the true pelvis, and then they could get randomized to either standard plus extended or standard alone. And so we registered 659 patients. We had kind of the expected amount of patients that were ineligible, and we're now at 6 years follow-up. We're reporting both the primary endpoint, disease-free survival, the secondary endpoint of overall survival, and the bottom line is there was no benefit to the extended node dissection with either of those oncologic endpoints, clearly establishing a bilateral standard node dissection as the standard of care. There was some increased toxicity in the patients that underwent the extended arm, predominantly grade 3 anemia, urinary tract infections, a little higher rate of sepsis, higher rate of postoperative ileus, and there was an increase in mortality, independent, so all-cause mortality, independent of whether it was attributable to the surgery or not. Those numbers are all well within, I think, what's accepted for both 30-day and 90-day mortality rates. I think that there's no longer a need to do a more extensive node dissection as long as you do your exploration and verify that there's no concern for metastatic disease outside the true pelvis. So I think we can kind of lay that to rest. I think now there's some really interesting questions about treatment intensification, de-intensification. This is happening a lot in not just GU cancer, but other cancers. And so can we use biomarkers? So there'll be a lot of translational medicine research that goes along with this trial. We've got about 350 to 400 tumor samples that we're going to do full sequencing. We're developing, we can apply molecular subtypes to try to identify maybe who should have treatment intensification, maybe undergo an extended node dissection, and those that are going to benefit or potentially just be cured with surgery alone. ctDNA may have a role in this pre-surgery. And then I do want to mention that there was a similar trial conducted in Germany that showed something quite similar. No benefit to progression-free or overall survival. They do have some long-term data that suggests there may be a benefit to cancer-specific survival, but the bottom line is you've now got 2 large randomized phase 3 trials that essentially, in my opinion, have kind of closed the book at this point.